Thank you, sir, for patience. Saurabh, sir, over to you.
Good evening. Welcome to the episode number 13 of our Renal classroom, Regan PG Renal classroom. I do not know whether it is a coincidence or not. Yesterday it was a Children's Day. We are wishing each of our family members, all the children's, happy Children's Day. And I was wondering that today's topic is nephrotic syndrome in a child pediatric population. I don't know whether it is coincidental or not, but let us look forward to this session. And I'm having privilege of welcoming our course director, who needs no introduction to all of us. However, with this particular small endeavor, I just would like to introduce our course director, Dr. Pratik Das, who is senior consultant nephrologist in Calcutta. He is attached to RNTH Hospital, and he is also the secretary of Eastern Zone Indian Society of Nephrology. So welcome you, sir, and let us look forward to have this particular session, invigorating session, wherein Dr. Edwin Fernando sir has also joined as an examiner. And welcome, sir, and wishing you all the best, Dr. Das Gupta, for your presentation. Thank you, sir. Over to you.
Thank you. Good evening. And
good evening, sir. Good evening.
So I'm happy to be associated with this forum. We shall be discussing a patient with childhood nephrotic syndrome today. So you will start the presentation. So I would tell you to make a presentation of about, let's say, about 12 to 15 minutes.
Okay.
So that we can have some time for discussion. Right?
Okay.
In between, I may interrupt you with some details. Otherwise, I wouldn't interrupt you. I would listen fully to you.
Okay, sir.
Right? Thank you. Thank you. Good luck.
But sir, if you please allow me, Dr. Das, would you like to introduce our examiner?
Nothing. No, nothing is required. Let's proceed. That's okay.
Okay, sir.
Everybody knows me. So let's no formalities.
Good evening, respected teachers. Myself, Dr. Somnath Dasgupta from NRS Medical College and Hospital is going to present a case today. My patient name is Miss X, age of 7 years, female, Hindu by religion, residing on Murshidabad, West Bengal, and by occupation, she is a student. Date of admission 07/11/2025 and date of examination 8th of November 2025, and informant mother and seems reliable. Chief complaint: puffiness of eyes and face for 9 days, swelling of legs and abdomen for 7 days. Now, history of present illness. I would like to date back my history about 3 years ago, when this child, apparently well, first developed puffiness around the eyes, noticed by her mother early in the morning. Over the next few days, the swelling gradually extended to involve both feet, legs, and abdomen. There was no history of fever, sore throat, rash, dark colored urine, decreased urine output, or joint pains preceding to this onset of this disease. Her pediatrician told the mother that she was leaking huge amount of protein with her urine and prescribed some oral medications. The swelling was subsided completely within 10 days, but she continued to take this medicine for 2 months, 1 month continuous or 1 month in alternate days. She remained well for several months thereafter. Over the next 2 years, from age 4 to 6 years, she experienced 3 more similar episodes, and each resolving completely with same medication. Between these episodes, she remained asymptomatic, active, and attended school regularly. There was no episode of red or cola colored urine, high blood pressure, or reduced urine output at any point during this period. In the past 1 year, She suffered from repeated 5 episodes of same pattern of illness and had complete response with treatment. Among them, 2 episodes preceded with minor cough and cold, and in the last 2 episodes, her mother noticed that the swelling tended to reappear soon after the medicine were reduced to alternate day dosing. Last episode 9 days back, but she was compliant to her medicine and then she referred from the pediatric department to us. For the last 6 months, her face became rounded and puffy, and she occasionally complained of burning sensation and pain in the upper abdomen, especially after meals, occasionally vomiting containing food materials, which subsided with medicines. There was no history of acne, excessive hair growth in faces, behavioral changes, visual problems, or bone pains. Appetite and activity remained fairly normal. No weight loss or growth retardation was noted. There is no history of fever, burning sensation in the urine, red colored urine or flank pain, decrease in urine output, no history of headache, convulsion, high blood pressure, rash, joint pain, oral ulcer, yellowish discoloration of urine and eyes. Currently now. Now history of past illness. No other significant past history, no history of surgery or drug allergy. Treatment history, received courses of prednisolone, probably, several times for her illness, receiving immunization according to her age, no history of NSAIDs or alternative medicine intake. Family history, no such illness in her family, born in non-consanguineous marriage, only child of her parents, no history of pregnancy loss of her mother. Birth and developmental history, term, cesarean section delivery, indication of cesarean section probably obstructed labor, birth weight 3 kg, no anti, peri and postnatal complications, developmental milestone normal for her age, student of class 3, scholastic performance good. Socioeconomic history, patient live in Pakka house, lower middle class, father has a small business, and personal history, bowel, bladder, sleep, appetite normal, no addiction. Now clinical examination. In general examination,
Let's pause here for a moment
okay, sir.
and then discuss. So, what do you think is the most likely problem here, and why do you say so? Let us define the syndromic diagnosis first, and then proceed.
Sir, my syndromic diagnosis is childhood-onset nephrotic syndrome.
Right. Why do you say nephrotic syndrome?
Sir,
What is the
nephrotic,
definition of childhood nephrotic syndrome?
sir, the definition of childhood-onset nephrotic syndrome is nephrotic range proteinuria along with edema or hypoalbuminemia. And by definition, the nephrotic range proteinuria is defined urine PCR more than 2 gram per gram or 24-hour urine protein more than equal to 1000 mg per meter square per day or urine dipstick more than 3 plus
Along with?
Either hypoalbuminemia or edema.
Fine.
And sir, but sir, in the extended definition is, sir, along with hypoalbuminemia, along with the hyperlipidemia and lipiduria. This is
Yeah,
also
if you read the recent definitions of KDIGO,
yes,
hyperlipidemia is now given up.
yes, sir. Yes, sir.
Yes. So, and when you're defining, there are different organizations giving different definitions. So I would advise you to stick to one and remember that well, because IPNA says something and KDIGO says something. So maybe a little confusing, especially when you're preparing for exams.
Yes,
so I'd advise you to stick to one group, one professional body that has given the definition. Okay. So you think this patient has got nephrotic syndrome. Further, would you like to classify and tell what is the problem this child is having?
This is a case of, sir, frequently relapsing nephrotic syndrome. And because there is more than 3 episodes of relapses in previous 1 year,
Yes.
1 year, and
Yes.
also it is a case of steroid SDNS, that is steroid dependent nephrotic syndrome, because during the tapering of the course of steroid.
So between the two, how would you define this?
Yes,
You
sir.
say FRNS and then SDNS both.
Yes, sir. Sir, FRNS is defined as more than two relapses within 6 months, or more than three relapses within 1 year.
Right.
And SDNS is two consecutive relapses during tapering of the prednisolone dose, steroid dose, or stoppage of the steroid within 14 days.
Right. So it would be better to call this as SDNS because the history is very clear that twice while the steroid is being tapered, the child relapsed.
Yes.
Right. Okay. So what do you think is the pathology in this patient?
Sir, the probable pathology is minimal change disease.
Okay.
And
So why do you say it is minimal change disease?
sir, the point for minimal change is the age of onset. The age of onset is 3 years. Childhood. The most common cause of childhood-onset nephrotic syndrome is
Okay.
MCD.
So in childhood, what percentage of nephrotic syndromes are due to minimal change disease?
So 70 to 80% of cases is minimal change disease.
Right. The literature mentions something like 65 to 70%. The rest are FSTS, of course, and very rarely other components. Right. So if you have somebody with an idiopathic nephrotic syndrome, as we call this, what happens? What percentage of them do respond to steroids? What percentage would relapse?
Sir, there is written in the KDIGO that more than 80% of steroid sensitive nephrotic syndrome is relapsed, and among them,
Now, how many percentage is steroid sensitive?
that is
Steroid responsive.
that is a 70%.
Right. So roughly, yes, good, right. Nearly about 70 to 80% respond. How many of them would relapse? What percentage would relapse?
Sir, among them, 80% steroid sensitive nephrotic syndrome is relapsed.
80% is a little too high. Maybe about 50% would relapse. Some of them would be frequently relapsing. Some of them would be steroid dependent. So this patient has got a steroid dependent nephrotic syndrome, right? So what is this is the pathology. So most probably we expect that this patient has got a minimal change disease, right? Okay. So what exactly is the pathology? What is happening? Why is there proteinuria? Why is there a minimal change disease in this child?
The histopathologically finding is the
I'm not asking you histopathology. We'll come to it a little later.
Right.
What is the main pathogenesis?
The main pathogenesis is T cell dysregulation.
Right. So let us say immune dysregulation.
Immune dysregulation.
Right.
Yes,
okay. So what are the factors that are, what are the pathogenesis that have been put forth?
Yes, sir.
Theories that have been put forth.
Sir, one thing is the Th to Th17 balance is disturbed.
Right.
So overproduction of Th2 and there is more T cell mediated injury at the podocyte. Second, sir, interleukin 13 interferon mediated injury of the podocyte. And during any infection, there is also interleukin 18 plays a role. So, sir.
So let's make it a little more simple. We will say that there is a circulating glomerular permeability factor, number one, right? Yes, this alters the structure of the podocyte slit diaphragm,
yes, sir.
The main component of which is nephrin,
yes, sir.
Right? And immune dysregulation nephrotic syndrome generally responds to steroids. Yes. So what is the evidence of the T cell and the B cell, role of T cell and B cell in idiopathic nephrotic syndrome?
Role of T cell and B cell?
B cell, yeah.
Sir,
have you heard of Childhood's hypothesis?
No, sir, I didn't.
Right. So please write down. This is Childhood, Shalhoub, Childhood, right? So Childhoub, way back in 1972, mentioned observations right? One is the association in children with atopy,
Yes, sir.
right? Number two, remission of proteinuria with measles. Number three, association with Hodgkin's lymphoma. All this suggested that there is a T cell dysfunction, right? And more recently, there have been there is a single cell RNA sequencing that shows some extrafollicular B cell response during active disease, and the fact that rituximab has been useful in patients who have steroid-dependent nephrotic syndrome also supports the fact that there is a B cell involvement also. Traditionally, it was thought to be a T cell mediated disease. Now it is believed that there is a B cell component also. Okay. Any more recent developments on this? Any other antibodies that is recently been described?
Anti-nephrin antibody.
So in 2022, anti-nephrin antibody was discovered. How was it discovered? How do you recognize anti-nephrin antibody? First on the biopsy, and then later you do the testing. Okay, so if you do the immunofluorescence, this is described as dusting pattern. The dusting pattern of the IgG. So co-localization of this anti-nephrin antibody along with the IgG, and this dusting pattern would suggest that there is an anti-nephrin antibody. Now, this anti-nephrin antibody is present in what percentage of patients? Okay, in children, about 22%, and in about 43% of adult. This is done by the ELISA. So this is otherwise known as the punctate IgG staining co-localizing with nephrin. Okay, otherwise called dusting pattern, right? Now, what is the importance of this anti-nephrin antibody? Is it just something that is present there as an antibody, or it has got more serious concerns or more serious uses of this?
The therapeutic benefit. There is an
right. So the autoantibody levels are absent or decreased in remission. And during, if you do plex for some of these patients, the antibody levels reduce, right? So this goes to say that there has been a circulating permeability factor. And during active disease, this autoantibody was present in about 80% of children, right? So other than anti-nephrin antibody, what are the other putative circulatory factors?
Sir, one is hemopexin.
Yes.
One is SUPR super.
Yes, very good.
One is CLC1.
Yes, CLCF1.
Yes, CLCF1.
Yes. Hemopexin.
Hemopexin, yes, sir, I told.
Right. ApoA1.
ApoA1, sir. ApoA1.
And angiopoietin like
ANGPTL4.
Right.
ANGPTL4.
So just remember 2 or 3, because if you're asked, you shouldn't draw a blank there. So okay, 2 or 3 things that you remember so that you can rattle it off. Right. So we can describe this as 2 things. One is autoantibodies, right? Like nephrin and anti-CD40, etc. And there are some circulating factors like SUPAR, CLCF1, and hemopexin. Okay. So what is the role of genetics in these steroid nephrotic syndromes, steroid-dependent nephrotic syndrome?
Sir, basically, sir, steroid acts as phosphorylates the actin cytoskeleton, the nephrin portion of the podocyte, and stabilize the actin cytoskeleton. In any cases where the nephrin is disturbed, there may be propensity to get steroid-resistant nephrotic syndrome.
Right. So if you take steroid-resistant nephrotic syndromes, 1/3 of them have some monogenic causes.
Yes, sir.
That is involving structural abnormalities of the filtration barrier.
Yes.
Okay. So in what situations would you do a genetic testing in nephrotic syndrome?
Sir, any case of steroid-resistant nephrotic syndrome?
Primary steroid resistant nephrotic syndrome, number one. Number
I must,
two, right?
sir,
Any congenital nephrotic syndrome.
any congenital nephrotic syndrome like
And
NP,
any child with nephrotic syndrome and some syndromic features.
syndromic features.
Right. What syndromic features would you look for?
Sir, osteodysplasia, and sir, in case of Pearson syndrome,
Yes.
Pearson syndrome, sir, SMARCAL1 mutation, sir, Finnish type of nephrotic syndrome.
No, but what will you look for?
Yes.
What will you look for? See, when you examine the child,
Sir, sensorineural.
you look out for these features, extra renal features that will alert you to a possibility of a syndromic disease, right?
Yes,
So Pearson's syndrome you mentioned. Okay. Anything else?
yes, Dennis-Dash syndrome, WT1 mutation.
Right. Right.
Sir, there is
So some abnormalities of the
SMARCAL,
eye.
SMARCL1 mutation. That is Skimin osseous dysplasia syndrome. The WT1, I cannot remember it.
So just look up these syndromes.
Yes, sir.
Because even the most important thing is the eye. Okay, they can have cataracts, they have myopia, strabismus, ptosis, retinal atrophy. Right. So in the genetic nephrotic syndrome, please look at the eye.
Yes.
Okay. Why is it important to look at the eye in somebody, a child like this that comes with the recurrent nephrotic syndrome? What else can be there in the eye?
That can be
Let us forget genetic causes. What else will you look in the eye?
steroid toxicity. I can find glaucoma or subcapsular cataract.
Glaucoma, cataracts. Right. Okay, fine. So in exam, this is very important because in the examination, if you find this and if you say, I look for this, then if the examiner is going to ask you, why did you look for this? Then you're going to say, I was looking for syndromic features. Why you look for syndromic features? I would do a genetic testing. Right. In what are the advantages of doing a genetic test?
And in genetic testing, we can avoid the unnecessary steroid exposure.
Exactly. Very good. Excellent. Limits unnecessary exposure to steroids and immunosuppression, especially in a growing child. Right? Okay. Any other advantage of doing this genetic testing?
Some genetic variant of nephrotic syndrome can respond to specific therapy, like say CUBN mutation can respond to B12, CoQ mutation can respond to CoQ enzyme supplementation.
Very good. So there is a ADCK4 mutation that functions with the Q10, CoQ10 pathway. So it provides an opportunity to provide targeted therapy. Right? And very important, in case this child lands up with renal failure, selecting a donor, it would be useful. And prediction of post-transplant recurrence, because generally the genetic
do not recur.
Yeah, it doesn't recur, except this anti-nephrin antibody, of course. There could be some issues. Okay, fine. So this child had nephrotic syndrome and has had frequent relapses.
Yes, sir.
Isn't it? And we believe that this child has been compliant with the medications.
Yes, sir.
Okay. What complications of nephrotic syndrome would you expect?
So first, I am expecting any case of venous thrombosis.
Sorry?
Venous thrombosis, sir. DVT, deep vein thrombosis.
Right. Very good.
Deep vein thrombosis. Any case of infection.
So is it only deep vein thrombosis? Thrombus can happen anywhere, isn't it?
Yes, sir. Thrombosis can.
So let us say thromboembolic complications.
Thromboembolic complications.
Right. So it can happen anywhere. It can happen in the artery. It can happen in the vein also. Okay. Yes. Right. Okay. What else?
Thromboembolic complications. Infections.
Yes. Why are they prone to develop infections?
Sir, there is large amount of immunoglobinuria. IgG is excreted from the urine, and also complement regulating substance like factor B, factor D, that is
Yes.
also excreted in the urine.
Right. Right. So
So,
piperidine, factor B,
and
all these are excreted in the urine along with other proteins. One. Number two is in the leg, the skin is stretched out and there's a lot of fluid beneath in the subcutaneous tissue, and so they are prone to develop infections.
infection.
Right. Okay. Any other complications?
Sir, a patient may develop acute kidney injury,
Okay.
and also,
What are the causes of acute kidney injury in somebody with nephrotic syndrome?
sir, one cause is hypovolemia.
Right. So
Second,
any acute kidney injury, you always follow the rule: pre-renal, renal, post-renal.
okay, sir.
Right. So tell me, what are the pre-renal causes?
So the pre-renal causes are mainly due to hypovolemia
Right.
and drugs like NSAIDs.
So instead of saying hypovolemia, it would be ideal to say effective arterial blood volume is low in nephrotic syndrome. Right. Number one. Number two.
Number two, sir, drug mediated like
What drugs?
NSAIDs,
NSAIDs. Okay.
NSAIDs diuretic induced. Sir,
Diuretics. Yes.
this
Anything
can
else?
cause this can
Any
sir,
other drug?
yes, sir. Sir,
Any other?
sir, any other drugs, sir, like sir, that can cause ATIN. Sir, this is, sir.
So tell me, in the context of nephrotic syndrome, what are the drugs that we use? More than NSAIDs, what are the drugs that we use? We use diuretics and we would use ACE inhibition.
ACE inhibitor. Sir,
So
diuretic.
sometimes when there's a combination of ACE inhibitors and diuretics on top of a low effective arterial blood volume, that is a potent reason for somebody to develop acute kidney injury.
Acute kidney injury.
Okay. Anything else? Any other drug used
Sir,
in the treatment?
Sir, pamidronate, interferon B, there are, sir, also can cause. Sir,
No. Treatment, management of nephrotic syndrome.
Okay, sir. Sir, some beta-lactam antibiotics can causes ATIN,
Interstitial disease. Okay.
interstitial
Right.
nephritis,
Right.
and
Can CNI produce AKI?
yes, sir.
Oh.
CNA can produce it.
So pre-renal and then renal. So in the renal, there is a glomerulus, tubules, interstitium. So if you go compartment wise, it's easy to remember, right? Okay, fine. So not in minimal change or FSGS, but in some other nephrotic syndrome, a crescentic GN can happen,
Yes, sir.
right? Somebody has an IRGN and suddenly there is a worsening of creatinine, you suspect a crescentic IRGN, right? Somebody with IgA nephropathy can develop a ATI after a bout of macrohematuria. So since you brought up this topic of AKI, I'm asking you what are the causes of AKI
Yes,
and how you would deal with them. So always keep thinking, whenever there is any recent worsening of creatinine, always look into your drug list to find out if there has been something that triggered this decrease in GFR.
yes,
Okay, right. So our diuretics, like even in addition to hypovolemia, thiazides and furosemide themselves can produce interstitial nephritis.
interstitial.
Right. Okay. Fine. What any other complication? Suppose this child has got a TSH of 14. What is your thinking?
TSH of 40, sir, there is loss of thyroglobulin.
Yeah. Right.
So
Thyroid
TSH
binding
is
globulin.
increased.
Exactly.
We have to
Then can these children have anemia and vitamin D deficiency, and why?
Yes, sir. Because the cause of anemia mainly nutritional, maybe, or maybe due to anemia of chronic disease, and there is steroid also plays a role here because steroid.
Can the iron binding proteins be lost in the urine?
Yes, sir.
So that is a more common cause. Of course, nutritional anemia is there in all our children, right? Okay. What about vitamin D?
There is, sir, also vitamin D deficiency.
Right. So when you're asked for complications of nephrotic syndrome,
Yes,
you must rattle out 5 or 6 immediately. So don't forget spontaneous bacterial peritonitis.
Yes,
You mentioned infection, but then
infection.
particularly you must mention spontaneous bacterial peritonitis. Right. Suppose the child comes with seizure, what would you think?
Sir, what?
Comes with seizures, presents to the
Yes,
emergency
sir.
with seizures.
Sir, it is maybe cerebral sinus thrombosis.
Cortical venous
Cortical
thrombosis,
venous
yes.
thrombosis and cerebral
What
sinus.
else can it be? This child is on treatment. What else can it be?
Sir, on treatment. Sir, it can be cerebrovascular accident also.
Why should a child 7 years old develop cerebrovascular accident?
Sir, hypocalcemia. Sir, there may be chances of
Hypocalcemia can produce seizures and tetany. Okay.
and tetany.
Right.
Sir,
Anything else? Could it be cyclosporin-induced seizures? I said the child is on treatment. CNI-induced seizures, right? Right. And please remember that all these patients, when they are in immunosuppression, they can develop infections. One infection that you have to always remember is tuberculosis, TB meningitis, or somebody developing a tuberculoma, right? So you have to think a little holistically. So not only the disease-related complications, but also the drug-related complications. So any problem always divided this way: disease-related, drug-related, or disease-related, treatment-related. Easy to remember, and also when you present in the exam, it's quite impressive when you classify your answers and then you answer. Right? It helps you to remember easily. That's the main thing. Okay, fine. So let's move on. We've had a good discussion on this. Let's move on to the clinical examination. So your inference here is that this child has got a nephrotic syndrome and it is steroid dependent. As of now, the child has not had any complications.
Yes, sir.
Right? Complications of the disease, nor the complications of treatment, as from the history.
Sir, complications of the treatment is or puffiness of moon phases and the acute gastritis.
Right. Yes. Noted that.
Okay.
Fine. So go on to the examination.
So general examination, the child is conscious, alert, cooperative, lying comfortably in bed, moon phases, and she appeared well nourished but edematous. And in vital sign, pulse 90 per minute, regular, normal value. All peripheral pulses are palpable, no radial or radiofemoral delay. BP 100/60 mm of Hg in bilateral upper arm. Respiratory rate 20 per minute, regular, no use of accessory muscles. Temperature normal. Oxygen saturation in room air 98%. Weight 24.5 kg. Height 123 centimeter. And it is within median 50 percentile of growth chart. And no gross skeletal deformities. And in general examination, pallor negative, cyanosis negative, clubbing negative, jaundice negative, edema 3+, neck vein negative, and lymph node and thyroid are normal. In systemic examination, abdomen is uniformly distended.
Here you must also mention that there are no genetic features, so syndromic features.
No syndrome.
Right. Especially if you concentrate on the eye, that will be great. Okay. So, suppose this child has got cerebellar features, what will you think? He's got ataxia.
Ataxia.
Have you heard of Joubert syndrome?
Yes, sir. Joubert syndrome.
Joubert syndrome is associated with the midline cerebellar vermis degeneration. Right? Okay. Fine.
Sir, abdomen uniformly distended. Flanks are full. Umbilicus slightly stretched but not elevated. Central in position. Skin is smooth without stria, scars, or visible venous engorgement. No visible peristalsis or palpable muscles.
Okay.
And no guarding or rigidity. And shifting dullness is present.
Right.
And auscultation is normal.
Right. Did it? Okay. Fine. In a male child, you would definitely examine the genitalia.
So genitalia.
They could have this is a female child, that's okay, but a male child, you will definitely examine the genitalia, look for hydrocele. They could have a patent tunica vaginalis and may have a hydrocele whenever there is ascites. Okay? Fine. So how will you manage how will you investigate this patient? How will you manage?
Sir, first I have done a urine dipstick, which is 3+. Which
3+ for what?
3+ protein, no blood, no glucose.
Your dipstick detects protein or albumin?
Albumin.
Albumin. So be very clear. Again, clarity is required. What is the principle of the dipstick? How does the dipstick function?
Sir, there is a reagent, tetrabromophthalone blue.
Right, very good.
Sir,
So that
this,
is not a reagent, that's a buffer.
sir,
That's a buffer.
yes,
Right,
sir, yes, sir, Papa. Sir,
right, right,
the albumin attached to it and changes color according to its concentration. First, it is yellow in color, and it changes to yellow to deep green.
yes, yes. So this is called protein error of pH. So why does the color change? Because the pH changes.
Because of it.
So depending on the degree of proteinuria, the colors go from yellow to green, light green, and dark green, right?
Yes,
Okay, so please remember that this is protein error of pH,
protein.
right? Okay. How else will you confirm proteinuria?
Sir, I have to estimate for 24-hour urinary protein.
Right. Any other qualitative tests you can do as outpatient or in the side lab to detect proteinuria?
Sir, I can do turbidometry with acetic acid.
No, I
Sir,
want you to do the test. Simple test.
acetic acid testing. I can take urine in a test tube and heat at the upper portion
Right.
of the test tube,
Right. Right.
and then give some acetic acid and
Hmm.
again reheat. If that is clotted and
Right.
white cloudy appearance is, then it is positive for protein.
Right. So when you do a heat coagulation, this
It
is called heat coagulation test. When you heat the upper portion of the tube, proteins and phosphates both will get precipitated. If you add glacial acetic acid, the phosphates would dissolve. If it is not dissolving, then you know it is protein, right? Please read about another test called sulfosalicylic acid test. Very, very important test. Again, available in the side lab. So 5% sulfosalicylic acid, if you add to the urine, and then look at the flocculation and grade it 1 to 1 plus 2 plus 3 plus 4 plus, right? So this is very important because in which situation do you have a negative dipstick and a positive proteinuria? Not in connection with this patient, of course.
In case of overflow proteinuria like
Right,
paraproteinemia, I
right.
can
So,
get.
correct. So, you must do this test yourself. Okay, fine. You will check for protein. Okay, then what else will you do?
I will check for protein. I will check for.
What is the sensitivity of this dipstick?
Sir, it cannot.
How much less protein can it detect?
Sir, it cannot detect microalbuminuria
Yes, that's right.
because
So up to 10 to 20 milligrams of albumin can be detected by the dipstick. For the sulfosalicylic acid test, it can detect up to 5 to 10 milligrams of per deciliter of protein. Right. Okay. What are the causes of a false positive dipstick?
a false positive dipstick can be in infection. If the urine pH is alkaline, uh,
Yes, alkaline urine.
alkaline
Yes.
because of urine alkalizer or protease infections,
Yes.
and
Right.
uh,
Presence of hematuria.
presence of
And
hematuria.
if within 24 hours of exposure to contrast media, these are three common causes of false positive dipstick. Okay. So how much of how will you measure the 24-hour urine protein?
The 24-hour urine protein I can by measure immunoturbidometric, immunonephthalmometric measurement. Also, HPLC method. Also, there is radioimmunoassay method is 2 albumin. That I can weight-based radioimmunoassay method that I can measure in this way. And there is also pyrogallol red test to measure the 24-hour urine protein. Sir.
Yes, yes, correct. So this, when will you do the urine PCR? At what sample of what time of the day?
Sir, urine PCR we generally do in the First morning sample.
Okay. The
First
early morning sample can underestimate the protein excretion by nearly 20%. So mid-morning sample will be ideal, right? When is this test not reliable? When is the urine PCR not reliable? When the GFR goes less than 30,
Yes, sir. Yes, sir.
this test is not
That's
reliable.
not reliable.
Right. Okay. Have you heard of the Neptune cohort? What is it?
No, sir. Neptune cohort. No, sir.
You're not sure? Okay, please go and read about it.
Okay, sir.
It includes about 850 patients. It's a cohorts of nephrotic syndrome patients where from a lot of inferences can be derived. Okay, fine. So you will do a urine examination. What will you look for in the urinary sediment of this patient?
Sir, I can see the oval oval bodies
Oval
like
fat
tubular
bodies,
tubular epithelial cells with fat
fatty
with
casts,
fatty casts and
yes.
oval fat bodies and
Hmm.
uh, there may be
Under polarized light, what does it look like?
sir, under Maltese cross
Maltese cross
Maltese
appearance.
cross
Yeah, very
appearance
good. Excellent.
Maltese cross appearance.
Excellent. Very good. Okay. In the clinical examination, you have to mention some nail changes that can also help you to make for the chronicity of the disease, like Mies lines, Bewes lines, Terry's lines, etc.
Yes,
So these are things that you tell the examiner that I look for these things. You're also creating a good impression that you have read the subject well and you look for it. Okay.
okay, sir.
What is half and half nails?
Sir, due to hypoalbuminemia, there is half and half nail signs.
No. Say it again.
Sir,
There
half and
should be no mistake in this. Half and half nails means,
sir,
well, otherwise called Lindsay's nails, very typical of CKD,
CKD.
right?
Sir, mucus line is for hypoalbuminemia. Sorry, sir.
Yes.
Sorry, sir.
Fine. Okay, so eye and the nails, if you concentrate, that will be good. Another thing, the examination look for striae. The striae could be part of the nephrotic syndrome or could be part of the steroids. Okay, so these are relevant clinical exams. For example, I need not tell no cyanosis, no clubbing, no lymphadenopathy. It's of no relevance to this particular patient. So your general examination and clinical examination should be relevant to this particular patient, right? Okay, fine. So we are done with the urine examination. What else will you do?
Sir, I can go for management first.
No, you have not checked the renal functions. You have not done an ultrasound.
Yes, sir. Oh, okay.
No.
Okay.
Let us complete the investigations.
Sir, investigations. In investigation, I must do a serum albumin.
Yes.
Serum albumin, urea, creatinine, and also I should check sodium, potassium, and
again the
calcium.
KDIGO mentions two methods of estimating the serum albumin and defines the serum albumin depending on what method is used. Kindly look it up. Okay. Right.
Sir, also I should check the electrolytes and uric acid. And
what will you look for in the electrolytes? Suppose this child has got a sodium of 128. What does it mean to you?
Sir, I must rule out this is hypervolemic hyponatremia or hypovolemic hyponatremia. I must check for FeNA. If this is if the FeNA is less than 2%, so I could say that patient is volume contracted. Right.
One is the part of the nephrotic syndrome. Many other cause of hyponatremia in this child.
So this is maybe due to steroid withdrawal, abrupt steroid withdrawal. There may be additions and secondary.
Yes.
Can be present.
Or this hyponatremia may be part of some other treatment. Very commonly used.
Very commonly diuretic treatment.
So which diuretic?
Sir, hyponatremia, sir, most commonly is thiazide diuretic.
So generally, we don't use thiazide diuretic in somebody with nephrotic syndrome. So we may use a thiazide-like diuretic,
Other light diabetic.
like metolazone,
Okay.
right? Okay. Suppose this child has got hypokalemia, what would you think? Potassium is
Sir,
2.5.
sir, hypokalemia may be due to diuretic and
Yes. Yes.
and
Fine.
and sir, and maybe due to steroid related toxicity spectrum of there may be
Fine. Suppose the
nutrition.
bicarb is 32. The venous bicarb is 32 in this child. What will you think?
Venous bicarb is 32. Sir, there may be there is a chances of metabolic alkalosis and sir,
Due to? Due
sir,
to?
due to diuretics.
Yes.
Diuretics, sir.
That's all. Hypokalemia, metabolic
Hypokalemia,
alkalosis related to diuretics.
diuretics.
Okay. Fine. Okay. Other investigations?
Other investigation, I should check for imaging like
Yes.
ultrasonography of whole abdomen,
Hmm.
and I should check for the volume overload like focus in IVC collapsibility more than 50% or not,
Okay.
and I should check for any renal vein thrombosis or not, and as a whole,
You need not routinely look for RBT. In what circumstance would you look for an RBT?
we do not routinely look for RBT, but
So
when there is
when will you
acute
suspect RBT?
acute onset of pain
Pain,
or
loin pain.
decrease in urine output, hematuria, I
Yeah.
can look for RBT.
Think of RBT. Okay. Fine.
Uh, the sir, I will also look both kidney with and also look for the ascites as present or not.
Yes. Agreed. Fine. Other investigations?
Then I will check for PTA, PDT, and the coagulation profile. And
Okay.
I will also check for there is any sepsis or not. So I will go for routine blood along with
What blood test?
says CBC,
CBC, yes.
CRP, and I can also do an procalcitonin for if there is any.
Why do you want to do procalcitonin? This child did not have any fever or present you with any evidence of
No, sir,
sepsis.
I will not go. If there
So
is
let us channelize our investigations and let us not over investigate and cause loss of revenue to the parents. So let us be very specific with our investigations. And of course, you will do a CRP or a procal when you have a child like this with fever or some abdominal pain, or you develop the total count is high. That's agreed. Okay, fine. So how will you? Yeah.
I will also look for vitamin D, calcium, and
Yeah, you would look for that. Yes.
blood
Okay.
sugar, sir. Blood sugar, I
Right.
must check.
Okay. Okay. Agreed.
Yes, sir.
So what else will you do?
Sir, in investigation, there is.
You will take a chest X-ray because
Yes, sir. I will
this
take
child
a
has been
chest X-ray.
steroids.
This patient is also
Yes.
had pleural effusion. I will check any pneumonia
Exactly.
or pleural effusion to check.
So a child like this can come with the shortness of breath, maybe because of a pleural effusion, maybe because of a pneumonia, maybe because of a pulmonary embolism. Right?
Yes.
Okay. Fine. Let's proceed with the. How do you treat this patient now?
Sir, we must treat the patient. We first stabilize the patient and give proper nutrition. And as
Proper nutrition means what?
So proper nutrition means proper protein intake according to our age, 0.8 to 1 gram per kg,
Right.
and extra protein for daily excretion of daily for to make up the daily proteinuria.
Okay.
And sir, there is sir, I also supplement the vitamin D and calcium, and sir, I also give her PPI. Proton pump inhibitor to reduce the GI irritation and ulcer, and we can shift
While the child
oral.
will not do well with ranitidine, why to give PPI? Considering the fact that PPI has been implicated in many issues, one of which is the kidney.
Yes, sir. Tubular
Right.
restriction
Yeah.
nephritis.
Unless the child has got some GE bleed or something. Okay.
Yes, sir.
Fine.
Uh,
Proceed.
Sir, then I should assess the volume status. If the patient is volume contracted,
Mm.
then I will give albumin and diuretics to reduce the edema.
So in somebody with a classic minimal change disease, what is the plasma volume generally?
The plasma volume is, sir, less because, sir, it
In
is,
all patients? In all patients it is less, or only in a particular group of patients it is
sir,
less?
most of the MCD patient follows the underfill theory. So, sir, the plasma volume is generally
Right.
contracted.
So in about 50 to 60%, they could have a low plasma volume, and the rest can have a normal plasma volume or even an increased plasma volume. Okay, so fine.
Sir,
What
we will
else?
check for, sir.
So
Sir,
you will give albumin, you will give furosemide. What will be the dose of furosemide you will give for edema?
sir, the initial dose, sir, initial dose, I must start with 4 mg per kg.
Right. You can start at 2 mg per kg and go up to a maximum of 6 mg per kg.
Okay.
Okay. Right. Okay. Suppose there is furosemide resistance, what would you think? Child is not doing well.
Sir, in hypoalbuminemia, there may be furosemide resistance
Yes.
because it
Yes.
is mostly protein bound
Yes.
and it's less bioavailable, so that
Yes.
it will not transport to the tubular lumen via albumin if there is there is hypoalbuminemia.
Yes.
So, sir, there is chances of furosemide resistance. So we
Mm.
can convert it to torsemide, which is more lipid soluble, more
Okay.
bioavailable,
Okay. Okay.
or we can give
Fine.
sequential
Mm.
blockade.
Yes. If you give a sequential blockade, which drug would you give first? Suppose you are using metalazone and furosemide. Which one will you give first?
Sir, in first I will give loop diuretic. It in any case, then
No,
I
no.
can
When
give
you're
metronidazole.
giving two diuretics, which one will you give first? Of course, you'll start with the loop diuretic. You will add on a thiazide, right? But when you decide to give two, which one will you administer first?
Sir, sir, I must administer the long-acting drug. In this case, this is metronidazole. I
So
can
you
give
will give
metronidazole first.
metalazone and then give an interval before you give.
I can block distally. Then I will give twice daily furosemide dose.
Right. Okay.
Sir, then sir, we give the specific therapy.
Right.
I have to I have to make the make clinical remission of this patient
Okay.
by giving steroid.
Yes.
But this patient has steroid toxicity. To reduce this
Mm.
local steroid effect, I can convert it to IV methyl prednisolone in wet waste format, like
Mm.
0.8. I can
Mm.
multiply into 0.8 and I can give IV methyl prednisolone, and I can try to remit this proteinuria to
Mm.
normal range. If there is
Again, there's no clarity on that. So uh, you can always say what you follow in your hospital during the exam. Say this is what we follow,
yes,
but there's not much of clarity on the use of IV methylprednisolone. Okay,
okay,
right. So be careful when you're saying that.
okay, sir.
Okay.
Sir,
So your aim is to achieve remission with steroid because
yes,
every time she's responded well to steroids. Now, what will you do to sustain the remission?
sir, then I will bridge steroid for another 2 weeks on alternative basis, and I will subsequently started with steroid sparing agent.
So you will give 8 weeks of steroids or 16 weeks of steroids?
So this is childhood-onset nephrotic syndrome.
Mm.
I will give steroid
Mm.
as per the protocol of the relapse. So I will give daily steroid
Mm.
uh, at dose of 2 mg per kg, maximum 60 mg.
Right.
So when consecutive 3 days dipstick is negative, I will shift to alternate day regime, and that point also I will start
Suppose you
the
had
steroid
seen this
sparing
child.
agent.
Suppose you had seen this child at 4 years, and in the first episode of nephrotic syndrome, you started treating. How long will you give steroids?
Sir, in first episode I will give 4 weeks, and then I will shift to alternate day steroid regime. If there is no complete remission within 4 weeks, I can also give 2 weeks more. Then I will give alternate day regime for
Right.
another
So
6.
please read about a trial called the Prednose trial.
Yes, sir.
Prednose trial. Prednose trial 1 that was published in 2019, where in patients with the first episode of steroid sensitive nephrotic syndrome, there was a theory that if you give a prolonged course of steroid, the relapses were less. So this was a trial that proved that this is not true. So they compared 8 weeks and 16 weeks and did not show any benefit of 16 weeks. And does it increase the time to first relapse? No, right? Okay. This patient has had recurrent relapses. No, so what can trigger a relapse?
Sir, any kind of viral infection.
Viral infection. So mostly respiratory infections,
Respiratory viral infection.
and generally virus. So when there is a viral infection, what do you do to the steroids?
Sir, there was previous guideline. There is continuation of steroid in low dose during the
Yes.
episode of viral illness, but current
Right.
guideline says give extra 3 dose of.
Yes. So this current guidelines that took away this stress dose of steroids is based on what trial?
Sir, this is most probably propion trial.
Yeah, one is the propion trial.
Propion trial.
There's another trial called the Prednos 2 trial.
Prednos 2, yes, and Prednos 2 trial.
Prednos 2 trial was published in March 22. Okay. So at the start of UTI, people gave 6 days of prednisolone, 15 mg per meter squared. And it showed that there's no benefit of steroids during URI to prevent relapse. Okay.
Okay.
Fine. So what else will you do for this child now? You have achieved a remission. Yes. What else will you do?
Then I have to choose the steroid sparing agent. So in our institution.
Okay. Now there is a problem whether this could be a minimal change disease or an FSGS. So what do you think?
Sir, as the patient is, sir, within 12 years of age, and the disease is onset at her 3rd year. So, sir, I cannot go for biopsy. I will not go for biopsy. If any scenario it proves that it is a case of secondary SRNS, then we can go for biopsy. But in this case, I must treat it as a MCD.
Okay. Is there any marker in the urine that may help you to differentiate between MCN and FSGS? Have you heard of CD80?
Yes, sir. CD80.
If the CD80 is present in the urine, it is suggestive of minimal change disease. Anything in the urine that can give you a clue that this could be FSGS?
So super.
Super is no longer specific for FSGS, not widely available. A more simple test that can suggest to you.
Sir, hematuria, it can suggest if
Yes,
there is microscopic
patients
hematuria.
can have hematuria, yeah. 20 to 30% can have microhematuria, yes. Anything else?
And say urine podocyte, I can check. If FSGS, there is podocyte loss and
many patients with FSGS can have tubular dysfunction and they can have glycosuria.
Yes.
So if there is glycosuria without any explainable reason, then you must think that this is FSGS. Okay. All right. Suppose you do a biopsy and the biopsy shows a minimal change disease. What are the markers in the biopsy that will tell you that this could be FSGS? I am giving you a slide. of somebody with nephrotic syndrome reported as minimal change disease by the pathologist.
Oh, sir, the corroborative evidence of FSGS will be, sir, there will be acute interstitial injury or
Some
tubular
interstitial changes,
atrophy,
yes.
or
Right.
maybe there is global glomerulosclerosis, sir, or
How do you
glomerulomegaly. Sir,
expect
this
global
can
glomerulosclerosis in a child with nephrotic syndrome? There's only a child.
very, very rare, sir. There
Right. So let us talk about common
but,
things first.
sir,
Let us talk about common things.
say acute interstitial injury or say
Tubular
tubular
interstitial
or
lesions. Tubular interstitial lesions suggest FSGS, right? Anything else?
sir, glomerulomegaly.
Yes, very good. Glomerulomegaly.
Glomerulomegaly.
Yes, very good. Yeah.
Uh,
Okay. Anything else? Anything else specifically in the interstitium that will suggest more proteinuria and that it could be FSGS?
sir,
Have you heard of foam cells?
yes, sir, foam cells.
Foam cells in the interstitium, right?
Foam cells in the industry.
Okay. Anything else? Anything else in the immunofluorescence that may suggest that it could be FSGS?
Sir, there may be IgM or C3 plasma
Yes.
deposit.
So classically in an MCN, the IF is negative.
IF is negative. And
right. So if you find some IgM and C3 trapping, then it probably suggests FSGS. Okay. As you know that FSGS affects the juxtamedullary glomeruli and may not show. So how many number of glomeruli you require to safely diagnose FSGS or to say there is no FSGS?
Sir, there is a saying 20 number of glomeruli to
20
diagnose 10% area for it.
Right.
Yes.
Right. That's right. Any other marker that could predict relapse or remission?
Sir, any other marker?
Okay, forget it. I would tell you that if there is a decreased IgG excretion, it is a possibility that there could be remission. And if there's an increase in the alpha-1 globulin, it's a predictor of renal failure and tubular interstitial damage. Okay. Fine. So what are the indications for biopsy in this child?
Sir, indication of biopsy in this child, sir, this patient is, sir, prior, if this patient present as secondary SRNS, if the patient present as secondary SRNS, if there is unexplained decrease in EGFR, unexplained decrease in EGFR, or there is active sediments in urine, or if we use CNI for 2 to 3 years long, we can also do biopsy in this patient.
Right. Okay. So before starting, what are the steroid sparing agents that are available to you?
Sir, there is, sir, in our institution, we, sir, generally may give, in case of SDNS as steroid sparing agent, sir, we can check first Hep B, Hep C, and tuberculosis, and then we will give rituximab. And also we can give.
No, the question was, what are the steroid sparing agents? You would say levamisole.
Oh, sir, yes, sir. Levamisole, we can give 2.5 mg alternate day for 6 months. We can give mycophenolate 600 mg meter square BD, and we can give, sir, cyclophosphamide 2 mg per kg for 12 weeks.
So levamisole, MMF, CNI, cyclophosphamide.
And rituximab.
Second line would be rituximab.
Yes, sir.
Okay. So in this context, I want to tell all of you, there is a study by Dr. Aditi Sinha from AIIMS, Delhi, that's published in May 24. They tried to give 12 months of alternate day steroid and versus levamisole, and favored levamisole for such patients. So please read about the study. It's published in the Indian Journal of Nephrology. Okay. So tell me, how does CNI produce a reduction in proteinuria?
Sir, CNI stabilize acting cytoskeleton.
How?
It acts with synaptospondin.
Synaptopodin.
Synaptopodin, sorry sir,
Yes.
synaptopodin,
Yes.
and
Yes.
also inhibits the interleukin 2 mediated podocyte damage.
To some extent, yes. Okay. Then.
These two mechanisms.
So it is more of a mechanical
Mechanical, yes,
cause of reduction in proteinuria rather than
rather than
immunological.
immunological.
Rather than immunological. So tell me, how do you give rituximab? What are the indications to give rituximab in such a situation?
Then in case of SDNS or in case of SDNS in this patient, I can give rituximab in 4 doses with 375 mg per meter square,
Right.
1 week apart.
Hmm.
So 1 week apart, sir, and I can check response with checking CD19, and then we will give again rituximab if there is CD19 activity. So,
Okay.
sir, this is our protocol for giving rituximab, and before giving rituximab, we must check for hepatitis B and tuberculosis.
Yes.
Hepatitis C, and we must check for it.
Any other level you will check if available?
Sir, IgG level I can check.
IgG,
Immunoglobulin
levels.
level I can check.
Right. Right. So how does rituximab act to reduce the proteinuria?
This is SMPDL3B. First, in the actin cytoskeleton, and it stabilizes the actin cytoskeleton. Second, it decreases the B cell proliferation, so that B cell mediated injury cannot happen. These two are the main reason, and SMPDL3B, it binds with SMPDL3B and it inhibits degeneration of the actin cytoskeleton.
Okay. So what are the problems with rituximab?
Problem with rituximab, there generally there may be some infusion reaction, or there is activation of hepatitis B, and
Suppose your patient is HbSAg anti-HbC positive. How will you give rituximab?
if this patient is anti-HbC positive, sir, I must check for HBV DNA load. If the HBV DNA load is high, I must treat first HBV, and I should defer the rituximab administration. And in case of any active hepatitis
HbSAg, anti-HbC, you must start anti-CAVR and then continue the anti-CAVR.
Yes, sir. I can give anti-CAVR.
Yeah. So you have to give anti-CAVR.
Yes, sir.
Right. See, the other thing with the rituximab is the hypogammaglobulinemia, lung interstitial pneumonias, lung fibrosis, and the chances of pneumocystis jirovecii pneumonia also. Right? So that's why you have to put them on cotrimoxazole prophylaxis.
Yes. Hello.
Yeah.
Sir, I am audible.
Yeah, you're audible. I can hear you.
Okay.
Yeah. The what is the current thinking now on the treatment of nephrotic syndrome?
Sir, in this case, I can give rituximab with MFF maintenance with low dose of steroid. If it is low dose of steroid alternate days, less than 2.5 mg per kg. If the patient cannot maintain remission in this dose. So I can give the low dose steroid for daily dose for less than 2.5 mg per kg,
Right.
and I should taper within 6 months.
Okay.
And
More recent suggestions have been combination therapy, just like how you treat diabetes with SGLT2 and metformin, or even lupus now. The ULR says you have to combine two drugs.
Yes, sir.
So now the people are thinking about 8-week cyclosporin after achieving steroid remission. There's a French trial called the Nephrovir trial that studied levamisole for 6 months following complete remission. So they had a relapse-free survival at 12 months by 30%. And the German study called the Intent trial that has a combo of steroid and MMF. And the last is a trial where they, within 1 week of complete remission with steroid, they added rituximab 375 milligrams. So people are looking at getting into the remission quickly. Okay. So combination therapy is being suggested. It does not come in any guidelines, but definitely being thought of. And when you mentioned about this hypogammaglobulinemia, that happens nearly about 50% of patients. So one has to be very careful. The other problem with rituximab is its loss in the urine, number one, especially in patients with massive proteinuria,
Yes.
right? Then there is a long-term immunological impairment. There is a reduced vaccine competency, especially in this particular age group.
Yes, sir.
And rituximab, the FC portion can have 30% of times genetic polymorphisms. So they may make rituximab resistant. And it does not sufficiently deplete the memory B cells and the cells residing in the tissues and secondary lymphoid organs such as spleen and lymph node. Okay. So if you're able to measure the total B cells and the memory B cells, that will be different. Okay. So people are now talking about obinutuzumab, which has been cleared in lupus also. So it's a type 2 glycoengineered anti-CD20 antibody. And it has got a unique mechanism of action, strong homotypic adhesions, potent induction of direct cell apoptosis through non-caspase dependent pathways. Okay. So when there is a multi-drug resistant SRNS, what is the problem? What are we worried about?
Sir, we know multi-drug resistant FRNS is two separate drugs with distinct mechanism of action.
For more than 2 months.
More than 2 months. We can, if we give and the remission, we cannot achieve complete remission. This is called MD.
So renal failure risk is higher in this particular age group.
Yes, sir.
Right? Okay. In somebody with an APOL1 mediated SRNS, any treatment options are there?
Sir, APOL1 mediated SRNS.
APOL1. So please read about enaxipilin.
Enaxipilin, yes, sir.
So which is an orally active apolipoprotein. And it is an inhibitor of proteinuric diseases. APOL1 is not very common in our country, but in the African ancestry, it's much more common. So a steroid resistant nephrotic syndrome, what is the post-transplant recurrence? What percentage?
Post-transplant recurrence 30 to 30,
about 40%.
Sir.
So which form of SRNS does not recur in the transplant?
Sir, secondary SRNS.
The monogenic forms.
And monogenic SRNS.
Monogenic forms.
Yes, sir.
Okay. So what is now clear is that traditionally we thought there is a histopathology. We treated MCA and FSGS. Treatment was based on histology. Now our new understanding is it is a podocyte injury there are diverse causes. So depending on the injury pattern, the genetic and environmental triggers, and then this helps us to do targeted therapies like uh, vitamin B12, the CoQ10 pathway, etc. Age related vaccines have to be given. Particular vaccines that you will cover are pneumococcal
Pneumococcal
vaccine,
vaccine.
H influenza, right?
Yes, sir.
And
Varicella also.
yeah, and you have to give the vaccines after the immunosuppression levels are lower. Okay. So the 80% of steroid sensitive nephrotic syndromes achieve remission by puberty. Only about 5 to 20% persist.
Adulthood.
Mm. And what will you monitor in such patients? You will monitor the blood pressure, the growth, then the mineral bone disease,
Growth mineral bone.
vision, metabolic profile. Okay. So what has happened to this child now?
Sir, we have started prednisolone. First,
Yeah.
sir, as there is very severe edema, we cannot achieve adequate prednisolone in our system. So
Okay.
so we had started IV methylprednisolone for 3 days, and with diuretic and albumin, the edema is reduced. And sir, today we are planning to give a rituximab this patient. All the reports are come, and patient is already remitted. Already dipstick is negative for 3 days. There is no such signs of any venous or thrombosis, and infections also sir ruled out. And we will give a rituximab, and then we'll give rituximab weekly for 4 weeks. Then we'll plan to start MMF with low dose steroid. So that is our plan.
What is the definition of diuretic resistance? Where does it happen?
Diuretic resistance is not achieving adequate diuresis. Adequate diuresis. Adequate diuresis after giving the maximal dose of any diuretic.
So there's
So,
no
sir,
there's no definition per se of diuretic resistance. What is
there is
diuretic breaking
breaking.
phenomenon?
So there is a diuretic breaking phenomenon, sir.
What is diuretic breaking phenomenon?
Initially, the diuretic response is higher. Then after certain dose,
Yes.
there is dip in response. So that is called diuretic
Yes.
breaking phenomenon.
Yes. Yes. So the one thing that can tell you there is diuretic resistance is low urinary sodium.
Low urinary sodium. Yes.
But there is no optimal level beyond which you can say.
Less than 20.
Less than 0.2% in hypervolemic states can be said as poor diuretic response. What are the other causes of diuretic resistance?
So one is hypoalbuminemia.
Hypoalbuminemia, yes. High sodium diet.
Yes, sir. High sodium diet.
Poor compliance. Right? Renal failure.
Yes.
Decreased blood flow. Like the effective arterial blood volume is low. And the protein loss affects drug binding and delivery.
Yes.
Altered drug absorption, distribution, excretion, etc. Okay.
Yes.
So when you have somebody having a diuretic resistance, first you must assess compliance, check the drug delivery, evaluate the renal secretion, and identify if there is a impaired response to the diuretics.
Yes, sir.
Okay. Any others got any doubts? Anything in the chat box? Okay, I don't find anything in the chat box. Anybody's taking questions from the other members? Mr. Saurav or Dr. Pratik? Because I'm not able to see the chat box.
I think there is no question in the chat box. Yeah, I think you have
Can't change.
all the questions in so detail.
Okay.
No question in the chat box.
So have a clinical approach, right? Make sure you make a decent history and relevant clinical findings, relevant negative examination finding, what you would look for in this particular patient, like the ocular features, the nails, striae. So these are things that will tell you that your examination is oriented to the patient.
Yes.
Otherwise, it will become like no cyanosis, no clubbing, no no neurocutaneous markers. So now we are taking an exam at the highest level where our examination should be more. There is one anonymous attendee who was asking me, why not early morning sample for PCR? I did mention that there is a 30% underestimation of the urine, the protein creatinine ratio in the early morning sample. So even in the original Ginsburg study that came in 1993, I think. So that was said a mid-morning, midday sample would be ideal.
Okay.
And be very clear about the urine examination. You said dipstick means it's albumin.
Yes, sir.
And the SSA. So be very clear on that, because sometimes you don't get your basics right, then it creates a very bad impression. Okay. Have you done the dipstick yourself?
Yes, sir.
Okay. So tomorrow you'll go and do the sulfosalicylic acid test yourself. That's
Okay.
the best way to learn. You'll never forget.
Okay, sir. Okay,
Right?
sir.
So can we call it a day? I think I bombarded him with enough questions. Let him go and enjoy his Sunday.
No, sir. No, sir. I have learned a lot, sir. Please, sir.
Yeah, the learning process is always continuing. We also learn every day from our students. You have read well. You have answered well. Some more, little more details, and please read about recent information, trials, etc.
Okay.
Please read about the trial by Dr. Aditi Sinha, because that's Indian data. So that will keep you updated. And I would advise all the participants, please read the last 3 years of Indian Journal of Nephrology, because there you will get some Indian data. And one of these guys may be sitting there as your examiner. Somebody's published something there and he's expecting you to answer that. So please go through the last 3 years of the Indian Journal of Nephrology. Now, it's a beautiful journal. You can read the reviews and you can read some studies that have come from our part of the country. Okay.
Okay.
Thank you, Dr. Edwin, for the excellent class. We have also learned a lot. My job is to summarize everything, but we have already summarized. I think it is not required now. So second part is regarding the assessment of the student, because they are exam going student. They need some
Yes.
evidence from this class. So how he performed today.
Yeah, he performed reasonably well, except that a little more basics and some more recent advances have to be studied. I know it's challenging today in nephrology because it's very voluminous. So that is why case-based discussions are important, so that you because theory is voluminous. You just go reading about nephrotic syndrome, it goes on and on and on. And every aspect is, genetics is one aspect, diuretics, treatment, other drugs. So it's really huge. So please read specifics. If you have such a patient, these are the questions you would anticipate. Okay.
Okay. Thank you.
Thank you very much.
Thank you, Pratik, and thank you, Mr. Sai, Mr. Saurav, all of you for supporting this endeavor. This is something very, very important. this is very important because the students are with the unit for 3 years, and they get oriented to that teacher's questions. So exposing them to others, other teachers, gives them a different perspective, and that way it's very, very important. I do expose all my students to other colleagues so that otherwise they'll get bored with my questions. They know what questions I would normally ask. Though we keep reading, you can't expect them to answer all what we read. That's not fair, because we've been around for 30 years, but they are just learning, and there's a volume of information available, so they do not know which one to read and which one to take. So that is where the role of a teacher comes. So I must thank for supporting such endeavors. Every discussion we and share our knowledge.
Thank you, sir. Heartfelt
Thank
thanks
you.
goes to you for spending your invaluable time in this
Yeah.
particular platform.
Thank you. It's my pleasure. It's my pleasure.
Helping preparing the students all over India.
Yeah.
So my question to you, Dr. Das, are we going to have the OSCE session today with Dr. Aniruddha?
I have no problem. I will ready for
We
go
have a
for
second
OSCE
part of
session if
this
you.
class. Okay, the second part of this class, ready. If you wish, you can stay. This is a small OSCE session that will
Yes,
be
sir. Yes, sir.
present. You can
Okay.
participate also. So Aniruddha, please go ahead.
Good evening, sir. I'll be sharing my screen, sir. Is the screen visible?
No, not yet, sir.
Is the screen visible now?
Yes.
Yes.
So make it full screen.
This is the first question for Dr. Somnath. Kindly read.
Yes.
56-year-old male, known case of CKD5-AD, type 2 diabetes mellitus and hypertension, presented with emergency with severe shortness of breath, BP 220 by 110 mm of Hg, pulse 54 per minute. On ABG, it's shown pH 7.01, PO2 121, PCO2 14, bicarbonate 6, potassium 7.1, and lactate 2.01. What I cannot see the two options that is given. One is urgent HD and another is rapid. I cannot read because there is a window. Rapid serological negative. Okay.
Yeah.
Okay. Then after 10 hours, ELISA report was available. HbSAg positive, anti-HCV negative, HIV 1 and 2 negative. What step will you take before the machine use next for the exposed patient, and what temperature deactivate HbV? Sir, I must go for which mode? Which mode I select first? I will select hot disinfection and hot rinse, the first mode.
Okay.
Can you describe what are the things that are shown in the screen, and what will you choose for that after exposure to this patient?
Sir, in y-axis, this is shown the set the temperature. That's a temperature at which there is disinfection is done, and then the temperature of the water which is rinsed. This is showing, sir, in the screen, and it is color graded.
So, for the hepatitis B exposed patient, what you do? You would do a hot disinfection with a hot rinse.
Yes,
That was the option you selected.
yes,
Okay.
yes. I must send for the AGV DNA level, and I will start therapy accordingly.
Okay. So usually, what is recommended is that whenever a machine is exposed to a bloodborne virus, uh, the first thing to do is to use a hypochlorite based solution to neutralize the virus particles which are exposed. And so the first step here usually is a
Cleaning.
cleaning with a front supplied in which hypochlorite solutions are used, and then after that you go for a chemical disinfection based on temperature. So coming to your second question.
54-year-old male, known case of CKD5T on 3 weeks of MHD, diagnosed with Hep C on DAA 2 months. Now was shifted to dialysis center for his MHD. For his MHD, will you be separate using a separate machine? Sir, I must check for the ACV RNA level. So, patient is also on DAA for 2 months. To be negative or to be given in non-separate machine, that is giving to or any patient. So we must give dialysis with the patient in a separate machine, because the treatment duration is not completed. It must be given for 3 months, and I should check for HCV RNA level. Then after that, we will decide whether it will be shipped to normal machine or the machine allocated for hepatitis C.
So, are you aware of any guideline regarding the allocation of machine for the hepatitis C patients?
Sir, if sir HCV RNA level is negative, that is SBR is achieved, I can give dialysis in normal machine. We should not rely on the kit test, which may be positive for HCV.
Do you need a dedicated machine, or you can use the same machine for the other patients also?
Sir, I need a dedicated machine for HCV patient.
To answer the question that is given.
What will be the nature of disinfection between therapies? What mode we select? This is also, sir, the cleaning, then sir, hot disinfection and hot rinse. 4 and 1.
Different for hepatitis B and hepatitis C.
Yes, sir. Sir, we must give, sir, hot rinse also.
What is important, the temperature or the chemical?
Sir, the chemical is also required, and also, sir, the temperature is important. So, sir, disinfection and hot rinse. So these two would I must select.
So what do you mean by vertical transmission of infection in such patients?
Sir, vertical transmission means, sir, if any patients got HCV from this machine, which are used for this hepatitis for dialysis for this hepatitis C patient. This is called vertical transmission for one patient to machine to another patient. So
For a vertical transmission, one patient to other patient, from machine to patient.
Yes, sir, one patient to machine, then machine to patient.
Machine to patient. So,
Yes, sir.
so for C, it is not very important because of the viral particle size and entry into the machines. That is much lesser compared to the hepatitis B, because the smaller particle easily penetrates the filter and goes into the machine. Next question, Anand.
So just to briefly highlight on the fact that actually the KDIGO does not recommend using a dedicated separate machine for hepatitis C, primarily because the risk of transmission of hepatitis B is quite high. They stay stable in the external environment for more than 7 days, and the risk of transmission for percutaneous exposure is quite high. And even if we look at the sodium hypochlorite requirements, we see if we use the around 500 ppm, which is normally used for hepatitis C, actually does not deactivate the hepatitis B virus particles. So for them, the concentration is quite high, around 5000 ppm is usually used. And for when we talk about as we again were talking, that separate machine is definitively not advised or not required in hepatitis C, only advised when we have a hepatitis B patient. And during the what is recommended for hepatitis, this interpatient sterilization or disinfection for hepatitis C, no special disinfection or chemical based disinfection is not required, especially if we are using a single use or a single run machine. When we are using a single run machine, a normal hot rinse should suffice, like a normal patient. It should suffice. So whenever a center there is a new infection of a bloodborne virus, all the patients who have been possibly exposed should undergo a viral RNA or DNA based testing. And again, these tests highlight on the this textbook actually highlights on the points or factors wherever the lapses can occur, through which HCV or any kind of bloodborne virus infection may spread, like usage of injections or multi dosage vials or medications which can be used, or standard use of universal protections or universal hygienic measures should be followed through for prevention of in these kind of infections. And again, the temperature in the last, actually what we were saying, that the front cleaning, the difference between a front cleaning and normal disinfection would be that not a normal chemical disinfection would be that in the front cleaning part, usually hypochlorites are not warmed. They are not actually the temperature is not increased, because a hypochlorite may generate toxic substances or toxic byproducts. So coming to your third question.
Identify
The structure and its function. You can see this picture has moved a bit. The circle actually highlights where this structure has been used in the dialysis machine. So what is it and why it is used?
this is air leak detector.
That is
This is
You see the beside this air leak detector, there is a membrane, a small membrane.
Can you see where the machine is actually this is attached, means where the pipe has gone in? Because of the image, it's I don't think it's very clear. Yeah.
Can you remove the red circle?
Yeah. 1 second. Give me a second. I'll just remove it.
And show it the arrows.
This,
This
if
one.
you can.
This is a
This is the place. What it is? This.
yes. This is not air leak detector. I cannot tell.
And see the pipe outlet is coming from the venous chamber, and ultimately the blue means it all about vein.
Yes, sir.
So it is going, and before entering the machine there is a filter. What is the purpose of the filter and what is it called?
Sir, I cannot answer that.
So
Okay.
it is a pressure transducer. You can appreciate that it is. You can measure the pressure. Okay.
It's a transducer protector. Basically, the transducer is within the machine. So you use this to prevent, actually, this is used to ensure that only the air movements are there and it prevents movement of any kind of bodily fluids. So usually the filter, if it is kept dry, it prevents transmission of bloodborne viruses or any kind of infections through this circuit. So again, it's a hydrophobic filter, so it prevents getting wetted. Usually if it is wet, then the transducer needs to be changed. And again, any kind of a leak, then probably the disinfection of the internal filters and the housing must be done. So again, what is this? Can you identify the substance?
Back of a dialysis machine. And what is shown?
This is this is for sterilization of the dialysis machine.
Yes.
Disinfection of the dialysis machine. It contained citrate. This contains citrate most probably.
What are the chemicals you use? Basically, this is made commercially available by combining 2 or 3. But basically, what are the chemicals used for this machine disinfection?
This is so one is citrate, sir, and another is
Okay. So machine is taking the fluid. Now you can see.
Machine is taking the fluid, sir. Yes, sir.
When do you do that?
Sir, after dialysis. After all dialysis session in the night, we generally use this machine.
Each dialysis or after the end of the day?
End of the day, sir. End of the day.
It is like that. What is the recommendation from the machine? What is the practice?
That the temperature must be 80 degree centigrade, 80 degree centigrade, and it immediately follows the hot rinse.
So if you use the chemical, it will take more time.
So more than 3.
So for this reason, we don't give, but recommendation we should give this disinfectant should be used after each dialysis session.
Yes.
Okay, so this again, which you was mentioning correctly, it was citrosteril. It's used for it's basically used for heat disinfection. So it has bactericidal, sporicidal, as well as virucidal activities, and it also helps in decalcification, or that's a descaling of the internal machines, and it's a composed with citric acid, lactic acid, and malic acid. And again, the types of disinfection for hemodialysis machines are primarily hot disinfection and cold chemical disinfections. For a regular day-to-day use, hot disinfection is mainly done, in which disinfection as well as decalcification is done. Chemical disinfection primarily uses hypochlorite-based solutions, and they are mainly for antimicrobial, or whenever there is a blood leak or exposure to bodily fluids, they are mainly used for that. And for the other cold chlorides, then sodium hypochlorite is mainly used. And the other commercially available are like puristerile or sporotal. So again, the previous picture, there was this structure, and what is the name of this structure and what is the function of this structure?
Maybe they have to. No, sir. That's a plus. This
is also in the back of the machine. So we need to see the machines by rotating. It's very important for the safety of the patient as well as machine. Okay. Next.
Wait, controlled.
So this is basically a last stage filter which is used for the RO water that enters through the inlet. So mainly it's a polysulfone based membrane which is used to generate non ultra pure water, or it is used to generate mainly the endotoxin free or bacterial endotoxin free water for dialysate preparation. And again, the use of benefit of using these kind of this kind of ultra pure water is usually reduction in the inflammation as well as reduction in the oxidative stress. So this is something which I think mentioned.
This is when I can when dialyzer reuse I can think of. I can check the number of viable uh, dialyzer viability of the dialyzer. If it is more than 80%, I can use this dialyzer.
So what is
Dialyzer reprocessing machine.
Yes, sir.
We used to do the washing in hands manually. Now we use it in the machine.
Again, fiber volume, effective fiber volume, I can calculate. If it is more than 80%, I can use the dialyzer. I can reuse this dialyzer.
So what are the things actually done in this machine to the dialyzer?
Uh,
You will
I
disconnect
cannot.
the patient and just put it in the machine, or
Yes, sir. After sir, each session, sir, for each session, I can use this Renatron machine to clear the dialyzer and check for the bundle volume.
but initially you have to clear the blood. Now you cannot
Yes, sir.
the whole blood is going into the machine and machine gets infected. So you wash it by either saline or your RO water slightly in the higher temperature, then put it in the machine. It is only for the dialyzer, not for the tubing. Okay. And what does it do actually, this machine? And what is the disinfectant use here? Why this is different from the manual disinfection?
That measured bundle volume. I said I don't know about the disinfection. What disinfection is
Main purpose is not measuring the bundle volume. Main purpose is for the disinfection. You can see
disinfection.
they are also showing there is 77 means it is almost 80% of the bundle volume is there. And after washing, they just lock the system with some disinfectant. And that has to be replaced. Like a citro-sterile, there is also another bottle. You can see the green bottle on the right side that contains something. What is the chemical used for this disinfection? Are you aware of the dialyzer disinfectants?
Yes, sir. Yes, sir.
One is
I
formalin,
cannot.
I'm telling. What is the second one? Only.
Sir, it can.
So you have to be in the dialysis unit very meticulously, otherwise you cannot learn. These things will come and you have to know.
Yes, sir. Yes, sir.
Because we'll see more and more childhood steroid relapsing cases, then you will see this kind of problems in you.
Okay.
Next.
Okay, so
37-year-old female patient, known case of CKD 5D in 3 weeks MSD, HD vintage 1.2 years, initiated by right-sided IJV non-tunneled HD catheter, current access left-sided IJV tunneled catheter, right and left-sided radiocephalic AVA primary non-maturation. She has been facing the alarm multiple times since last few HD sessions. What does it signify? How will manage this issue? Can I see the previous slide? Right side IGB non-tunneled, current access, left side IGB tunneled catheter, right and left side radiocephalic AV primary non-maturation, right and left side radio. Okay. She had been facing this alarm multiple times since last few HD sessions. lower lower vein alarm. How does it signify?
See the picture.
How will
Only
how will
you see the machine. Base sessions are on all on machines.
so this is sir probably outflow stenosis. The blood cannot be returned properly. So
You see the machine, you see the tubing. The tubing with a red lock means it's an arterial line.
arterial.
And what do you see in the machine?
Sir, so there is clot. There is air in the sir uh,
So
arterial chamber.
it is air in the this is in the beginning part there is no air. In between there is some empty space. Then again there
Yes,
is
sir. Yes, sir. There is.
difficult. If it is air, then it should be all allowed. Blood is not coming properly. Okay.
Yes,
See the suction every time the pump moves, there is a suction. And you see the screen. What is the alarm?
there is a lower vein alarm.
So what does it indicate?
Sir, sir indicates that there is any block in the IJV, left IJV, a left IJV catheter, so that blood cannot come or go properly.
So you cannot suck properly at
Suction.
the speed you
There
have
is suction.
set. Okay. So there is a vein is getting less, so lower venous alarm. So what will you do for that?
Sir, I can change and make it access from in right IJV, sir.
No, no, it is in between dialysis. The patient is on dialysis. Now what will you do? What is the problem and what will you do?
Sir, I must return the blood. I must return the blood. Then I will, sir, I will end the dialysis session, and next I will check the patency of the left IJV catheter, and after it being patent by thrombolysis, then I will again start the dialysis.
Do thrombolysis and again start dialysis.
Sir, for some time being, I must stop the dialysis.
Stop the dialysis. If you don't stop the dialysis, what will happen?
Sir, air embolism can happen.
Yeah, because you can see this arterial chamber. This is a quite big chamber and no air inside. So why there will be air embolism? And this is automatic machine. There's a lock is there. Machine will automatically stop if there is air in the system. Okay. So you see what happened to this patient next.
She developed episodes of hematemesis. She was started on heparin-free HD with RBC transfusion. Despite multiple incidents of the initially shown alarm, the hemodialysis was continued. The machine started to show this alarm. What what will you think? What will you intervene?
See, the alarm is changed. There is a heparin is stopped, blood is given, and there is also inadequate flow, arterial flow. Your machine is showing some different alarm now.
Upper TMP alarm.
What is that?
So the transmembrane pressure is high. So that means there is disparity between.
So these patients have some risk factors for something. The low flow, heparin free, blood transfusion.
So there may be clot in the dialyzer, sir.
Yes. So if these are inadequate flow patient, they develop a lower TMP, then suspect the clot because in the whole extracorporeal circuit, the clotting starts in the fibers. Okay, it starts there, then it extends to the tubes.
Yes, sir. Yes, sir.
Okay. Next.
The HD was continued despite this. Now the machine started show this alarm. What we will think? What is the result of the outcome?
So continue
This is
dialysis, and now this is the alarm.
upper vein.
So your upper
Sir,
pulse is related to the machine, related to the mostly to the patient, and lower
patient.
pulse is related to the, okay.
Sir,
So
there
what,
may be, sir, outflow or venous obstruction so that the blood cannot go to the patient, sir. So the venous pressure is
so
in high, sir.
the things has gone wrong with the it is extend, it is outside the now fibers. It is now in the tubings also. The
Yes,
system has started to clot. Hmm?
yes, sir.
Okay. This is important, and this is emergency. You have to identify.
Yes, sir.
Next.
So that what you were telling regarding the key steps in dialyzer reprocessing, apart from identification and cleaning before actually or rinsing the machine before going into a dialyzer reuse based treatment, that in which you do a disinfection of it using multiple chemicals. Most commonly used or the commercially used is the Renalin, which is a composition of paracetic acid and hydrogen peroxide. And what you again correctly said, that the fiber bundle volume has to be calculated, whether be it a volumetric measurement or a weight-based measurement, and 80% of the rule of 80 has to be followed. That maximum 20% of total cell volume reduction is permitted, which actually represents around 10% reduction in the urea clearance. And in the previous thing, what we were seeing, that the lower venous alarm, which was mainly because of inadequate flow from the arterial end. Apart from that, other causes of venous alarm can be venous needle dislodgement, but which is pretty rare. Otherwise, any kind of link, disconnection or kinks or loose connections or even access infiltration may result in that. Upper venous alarm actually represents there is a higher pressure in the venous outflow end, and usually outflow obstruction or because of a stenosis or even a large infiltration causing compression of the venous outflow segment may result in that. Also, clotting in the circuit, needle malposition, as well as high blood viscosity may result in upper venous alarms. And again, upper venous alarm is comparatively much more common than a lower venous alarm. And when we look at higher transmembrane pressure, mainly we have to look for membrane getting clotted or circuit getting clotted. And also we have to look for whether there is an excessive generation of ultrafiltration rate, or are there any problems with transducers. Most common cause of usually having a low TMP is mainly malfunctioning of the pressure sensors, or it can be because of the membrane leak or rupture of the dialyzer membrane that can cause a sudden drop in the transmembrane pressure. So in this case, like there was an initial low venous pressure followed by elevated return pressure and high transmembrane pressure, which would indicate a dialyzer as well as a venous line obstruction. And again, the causes of arterial obstructions are quite few, like the venous catheter access, lines kinking and improper tink position can be there, or ball valve mechanism by a fibrin plug can be there. For arteriovenous access, like AV fistulas, we have to look for the position of the arterial needle, whether they are not getting impinged, or whether there is a decrease in the patient's blood pressure, as well as smaller needle, use of a small needle, or whether there has been movement and that caused the dislodgement of the channel can result in this. So with this, I would like to conclude the session. Thank you.
So we have to go to the dialysis unit.
Yes, sir. Yes, sir.
Because these things are important.
Yes, sir.
Because if there is a clot in the extracorporeal circuit, it takes away almost 180 ml of clot, means around 300 ml of blood. But you have to explain to the patient relatives, patient, and the patient is also at risk. And doing a thrombolysis, before doing a thrombolysis, you should do a chest X-ray. That can be done easily during dialysis to see the position of the catheter.
Yes, sir.
Okay. So with this, we conclude our session of this is the nice case presentation, nice discussion by Dr. Edwin Fernando. Shumnath has also presented quite nicely. And we always try to keep the OSCE sessions, which is something different from the main case presentation. And that has got some practical importance because after all, you are going to be nephrologist after some time. And you have to, other than passing an examination, you have to have some more knowledge regarding dialysis and transplantation and like that.
Yes, sir.
So thank you, Doctor. Thank you, everyone. And over to you, Mr. Shaw.
Thank you very much, sir. And that brings to the end of today's 13th session of Regain PG program. With that, childhood onset of nephrotic syndrome got over. My sincere thank goes to Dr. Pratik Das, sir, our course director, for guiding us to firm up the classes since 2024. And heartfelt thank goes to Dr. Edwin Fernando, sir, for spending his invaluable time for the class and preparing the students for the forthcoming examination. Our sincere thank goes to Dr. Aniruddha Datta for the OSCE session, and Dr. Aniruddha, Dr. Fernando has requested for your PPT slides after this particular session. And our deepest love and the best wishes to Dr. Somnath Dasgupta for his forthcoming exam. And at the same time, all the students present in this particular class and would be watching this class maybe in their leisure time, which would be available in the YouTube. I also would like to thank Mr. Amol, Mr. Sai, and the entire MicroCCD family for assisting me presenting Regain PG Renal classroom month after month. So with that, see you in our next session, and to be held in early December. We shall keep you posted on the next class, duration, time, and all further details. Till then, good night, take care. Thank you, sir. Thank you very much. Thank you, everyone.
Thank you, sir. Good night, sir.
Thank you.
Thank you.